I am Dr. Naga. I welcome you all to this webinar that is hosted by Navya. The topic is clinical application of next generation sequencing in solid tumor management. So we are starting this webinar as a series of expert insights, which will be helpful to all the practicing oncologists and all the enthusiasts to know more about these topics. I welcome the panelists, Dr. Bhavna Sirohi, Dr. Shona Nag, Dr. Anu, Dr. Suryavamshi, and Dr. Neha Pathak to this webinar. And I thank them for accepting our invitation and hosting this webinar. So with this, I request all of you to be attentive to the discussion. And I request the panelists to introduce themselves. To start with Dr. Bhavna Sirohi, ma'am, I welcome you. Please introduce yourself briefly and start the session, please. Thank you.
Hi, good evening, everyone. Extremely grateful to Navya, which is an amazing platform, as we know, in collaboration with Tata Memorial Center and National Cancer Grid, has been doing great work, not only in India, but in a lot of other countries as well, in providing second opinion to patients. And for me, I think the greatest thing about Navya has been that providing second opinions in a timely fashion so that the patient is able to get the opinion from site-specific experts within India. And all of the panelists are experts with Navya. I am a medical oncologist. I treat GI and breast cancers, and I am working at Balco Medical Center in Raipur. I would now like to invite Dr. Shona Nag to introduce herself.
Thanks, Bhavna. I'm Dr. Shona Nag. I currently work as a director of the oncology services at the Sahyadri Group of Hospitals in Pune, and I'm also a trustee of the Nag Foundation. Over to Dr. Suryavamshi.
Good evening, everybody. I am Dr. Maushmi Suryavamshi. I am the head at Amrita Institute of Medical Sciences and Research Center in the molecular biology section. And I now give the dice to Dr. Anu.
Thank you. Thank you, organizers, for this opportunity. I'm Dr. Anu R.I. I'm a physician scientist, currently working in MBA Cancer Center, Kerala, as a specialist in cancer biology and therapeutics, as well as head of clinical biochemistry department.
Hi, good evening, everyone. I thank Navya Foundation for this amazing opportunity and planning this series of webinars to encourage us to gain knowledge in this upcoming field. I am Dr. Neha Pathak, currently joined as Assistant Professor in Medical Oncology at the Institute of Liver and Biliary Sciences in New Delhi.
Do you want to say a few things about Navya, Dr. Naga?
Navya is a cancer informatics and patient services company. We use the technology of artificial intelligence and machine learning. And with the help of TMC and NCG experts, we provide personalized evidence-based cancer treatment plans, which will be helping the treating oncologist to take the final decision on the patient care. So this is what we do in Navya. And also along with that, we have started the recent webinar series, which will be helpful in knowledge sharing and experience sharing by the experts with all the oncologists and doctors across the country and across the globe. So this, we believe that we will be having these kind of series at least once in a quarter, and we'll get back to you with more learning sessions like this in coming days. So with this overview of Navya, I would like to request Dr. Bhavna Sirohi to take over the stage and please take us through the topic in question today.
Thank you, Dr. Naga. So great to welcome you all. So I'm going to just start with the question to the panelists, and I'll start with answering it myself. The next generation sequencing that we do in the clinics, as to when we request it, I will ask my oncology colleagues, but before that, I would like to say that next generation sequencing, we're going to discuss some cases, but there are a lot of challenges with it. Which test to order? It could be DNA based, it could be RNA based, and you'll hear from our experts as to which one we should order. It could be targeted with some targeted panel like we do in GI cancers. I would just do RAS, BRAF, and HER2 maybe, or MSI, and not do anything else. Or it could be a 50 gene panel. It could be a 500 gene panel. So there are a lot of options that are available, and there are a lot of companies that are doing these tests. Some of them are CLIA approved labs, some of them are FDA approved labs, some of them are done in India, some of them we send abroad. So I think it's very important, and this is something we will touch upon with Dr. Anu and Dr. Maushmi as well, as to what we should look at in the report. What is the depth of the coverage? What is the tumor content? When you look at the report, I think it's very important not just to see what they tell you, but it's also important to see what the tumor content was, what the depth of coverage was before, because these are expensive tests, and we as oncologists are making these decisions in the clinic based on these tests. So my usual instinct is that if I know that something works, like let's say breast cancer, I would only do ER, PR, HER2 in early breast cancer. In advanced breast cancer, I would do PIK3CA mutation and maybe ESR1 mutation with the data that is coming up. But other than that, we can do PDL1 in triple negative breast cancer and androgen receptor. But other than that, there is very little evidence to show what you should do. So I think for each cancer, we will have similar different biomarkers which we need to know, against which we had targeted drugs. The downside of NGS is in about 25 to 50% patients, we find nothing, no actionable mutation. So I tend to do it in patients where I know there is no standard of care, and I would usually do it in second line, third line. In breast cancer, maybe third line and beyond, which is a wider panel. I'd like to ask Dr. Shona when she would do NGS in her clinic. Would she do it in everybody, like in Sloan Kettering, any patient who walks in gets it done?
Yeah. No, I don't think we have that luxury in India. We've got to pick and choose our patients very carefully. And as Bhavna mentioned, certainly with things like lung cancer, non-small cell lung cancer, it's a no-brainer. You want a lung panel, you want to take a call on targeted therapies, which are so important with our patients. And for breast, it gets a little more blurred. And I agree, in the metastatic setting, it's far more useful. Of course, when you have rare tumors and you really don't know what to do with them, and very often they come to you metastatic, that's when you'll probably ask for a wider panel where you're looking at a whole lot of genes to look for something targetable. But things like MSI, things like PDL1, maybe, NTRK in the rare case, these have all got agnostic approvals where you certainly have drugs, at least for MSI and PDL1 and TMB, available in the form of immunotherapy in India. And when cases start getting a little difficult, when, like Bhavna mentioned, it's first line, second line, third line, then you would probably think of doing an NGS.
What about you, Dr. Neha? When do you recommend doing NGS?
Ma'am, I agree with all of the points that you and Dr. Nag have stated. Basically, it's a very individualized decision for our clinic, taking into the economic aspects, the availability of the treatments if a target does show up. So in lung cancer, definitely upfront, metastatic, advanced, NSCLC is coming in. Non-small cell lung cancer, I am thinking of specifically an adenocarcinoma, and in some formats also, that we would want a broad range panel, so NGS would be good. Again, colon, we do need a panel, either NGS or PCR, considered pretty equivalent, but we do need those markers. In ILBS, we get a lot of cholangio. Here we're trying to do it in the second line, although there is not a lot of drug availability. We run into that, unless if funds are not an issue, then it's not an issue, but that comes into a problem. Neither NTRKs are available currently, neither FGFR or IDH. So that is the issue. So I think multi-factors come in. And again, with TMB, we would need a wider gene coverage, wider DNA coverage. And if we're ordering a targeted panel, then asking the patient to get a wider 500 gene coverage, then that becomes a very tricky discussion sometimes. if we want a TMB later on.
Thank you.
One comment
So
to
I
add,
think-
Bhavna. One
Yeah.
comment. I think we've forgotten about germline. So I
Yes.
think that's very, very important. And we've got to remember that in gynec cancers, in breast cancer and colon cancer, NGS to pick up the germline mutations are very important.
Yes,
Yes,
absolutely.
actually, I wanted to add that. I thought that will come to me. But
I'm so sorry.
You
So
were
I'll come to you, Maushmi
Yeah.
and Anu. Basically, molecular tumor board, if you're ordering an NGS, please make sure that you are part of a molecular tumor board. And both me and Dr. Nag are going to be restarting the tumor boards that we used to do hopefully from March. And so that is the forum where you have a molecular pathologist, you have a panomics specialist like Anu, you have a clinical geneticist, you have a molecular oncologist, and basically the oncologist who is discussing these patients, because this is a big responsibility on our shoulders to be able to make the right decision for every single patient that comes to us. Next slide. So precision oncology basically is, we've already spoken about. Again, we do the biopsy. At the level of biopsy, how you do the biopsy is very, very important. Whether you have taken it in a neutral buffer formalin, it's very important that, you know, if you put it in normal formalin, you would not be able to find any DNA or RNA. So you must know when you do the biopsy how to actually fix the specimen, and then it's sequenced. It should come to the molecular MDT with the reports, with the scientists actually who have done the test, along with the oncologists, and then you come up with a plan. Next slide, please.
Can I add to that, Dr.?
Please, Dr. Maushmi.
Yeah, one thing which is very, very important, especially in cases of lung, is that you need an adequate tissue. So that's a
Yes.
big, big problem that happens, and it has to be addressed there and then. And if you're in a hospital setting, then doing a ROSE rapid on-site evaluation of the material which you get is very useful, because you do the entire exercise, and which may take 2 to 3 weeks if you're going for NGS, and you don't get any result after 3 weeks is very disappointing for the clinician as well as the patient. So that part has to be taken care right in the beginning. So has to be a coordination between the radiologist, the clinician, the pathologist, and the molecular person.
Absolutely. And in the molecular MDT, actually, you also look at the various magnitude of clinical benefit as to, you know, whether the actionable mutation, the treatment that you're recommending, what is the evidence on that? And various, there are various, ASCAT is one mechanism, ASCO has another mechanism that, you know, one can use to make those recommendations. Next slide, please. So the triaging of decision in a molecular MDT, you know, you have precision medicine with NGS profiling, you look at actionable genomic alterations, but you also have this MSI and TMB. TMB was an agnostic marker, but I think the recent ASCO CAP guidelines which have come up, which show that, you know, if a patient is MSI high, then one could, you know, consider a benefit with immunotherapy. But if it's MSI stable and TMB high, then one should not, the benefit with immunotherapy is going to be very small. So I think these are the nuances that one has to look into, that even though the patient may have a TMB high tumor, you should still look at MSI as well. Any comment, Anu, Maushmi, on this with the recent ASCO CAP?
Yeah, I feel even pole for that matter, if you have a pole mutation and a TMB high, so they are also very good candidates. And another thing, all MSI high or deficient tumors will not really respond. So Lynch syndrome patients do well, but you have to realize that that's not magic. This is not a magic biomarker, though MSI is the best biomarker for immunotherapy we have got till now. But still, it is not an absolute marker. And PDL1 is also there, which you have to juggle between 3 of them and come to a consensus. What is your best option?
Yeah.
Yeah.
Next slide, please. Anu, you say, yeah.
So when it comes to choosing immunotherapy, so many markers, so many biomarkers. These are very few which are even going to be outdated. TMB, if you see, if you're running a very small panel, may not be accurate. So the definition of TMB came from the whole cancer genome, which we aren't looking at the clinic level. So every marker has its own importance, and it's always a coalition of all markers that you need to check for before initiating immunotherapy.
Yes, absolutely. Next slide, please. And Dr. Naga, if you could start with the first patient, which came to Navya.
Thank you, ma'am. Thank you all for starting the nice conversation about the NGS with a nice introduction. So I will start the case presentation. This is the first case, that is pancreatic cancer. So the patient presented with first time in Jan 2018 with an abdominal distension. She was diagnosed. She underwent CT chest, abdomen, and pelvis, which showed left para-aortic lesion with signs of left retroperitoneal and pancreatic tile neoplasm, showing that there is a pancreatic tile neoplasm, which was done in February 2018. And then there was a US ultrasound guided biopsy, and the tissue showed a solid pseudopapillary neoplasm of pancreas. Surgery was performed. That was the distal pancreatectomy plus splenectomy was done in February. The margins, the final margins after surgery were negative, and perisplenic lymph nodes were negative. Lymphovascular invasion and perineural invasion were negative. And post-surgery, the patient was on follow-up till August 2020. So the entire follow-up period was uneventful. Then she presented second time with the minimal weight loss. That was in August 2020. Patient was diagnosed with CT chest, abdomen, and pelvis, which showed right liver segment 8 lesion. CA was 1.19, chromogranin A 35.81, CA 19.9 was 10.39. Liver biopsy was performed, which showed solid pseudopapillary neoplasm. IHC was positive for ARE cadherin, PR for focal positivity, and then beta catenin was diffuse, synaptophysin was diffuse, CD56 and cyclin D1 were positive. But IHC was negative for CD10 and chromogranin. Ki67 was less than 14%. Next slide, please. FDG PET CT showed 2 splenectomy bed lesions, which was indicating locoregional recurrence. There were multiple liver lesions also, which was indicating metastasis. Right paracolic gutter peritoneal nodule metastasis was also suspected. Few left lower cervical paratracheal lymph node, left lower paratracheal, para-aortic, subaortic, subcarinal, left hilar lymph node was showing positive for metastasis on the FDG PET CT scan. Surgery was done with right hepatectomy and intraoperative ultrasound-guided marginal excision of left liver lobe and en-bloc peritoneal metastasectomy. Final margin of surgery was negative, and lymphovascular invasion was positive, but perineural invasion was nil. Splenic bed involvement, right paracolic gutter nodule involvement was confirmed, and pelvic nodal involvement was present. So NGS test was performed, and the results are displayed here. So now I will request Dr. Suryavamshi and Dr. Anu to take over the discussion from here.
So
yeah,
I know how the patient is at the moment.
Yeah, she is an ECOG 0. She is on follow-up and she is on ECOG 0.
So this is a very rare case, right? So a pseudo papillary neoplasm of pancreas is usually
So metastatic SPEN, it's very, very rare. Yeah.
Very, very rare. And patients dying of it is even rarer. So what we have here is a copy number loss in FANCJ gene, which is also the BRIP1 gene. Okay, so this is one of the DNA repair genes. And though this report does show that there is FDA approved therapies for this, but unfortunately they are not. But yes, it is there. And then in the next slide, can you go to the next slide? It is showing that the other genes which are involved in the DNA repair, like PALB2 is negative, then HER2, which could be another thing for targeted therapy, BRAF, KRAS, they are all negative. And then there are these CTK, NNB1 gene mutations, which are found in around 95% of the pseudopapillary tumors. So that's in fact a diagnostic thing for this. So this, we are dealing with the same things, and it is very rare. In fact, on the histology, there are certain subtle features which probably were there or not there in the first surgery, which could have made us suggest that this patient could have an aggressive course, because usually it is not such an aggressive course. So that is one thing that should be looked in the initial biopsy. So it could have been predicted that this patient would be having such a course. That is one thing. And now, since what I am seeing here, can you go to the next slide? Okay, so in the next slide, it is showing that there are some unknown variant of unknown significance, and in the CTNNB1 gene. But this particular mutation is actually not a unknown mutation. It is a pathogenic mutation, and it is seen. So this probably is the driver of this tumor. And then there is some JAK3 mutation. Then there are FGFR3 mutation, but the coverage, Dr. Bhavna just mentioned in the beginning that you should be looking at the depth. So just look at the coverage. The coverage is very less. It is at 21x. So I would not like to consider such a mutation. So for taking it more significantly, or maybe I can, if I am feeling that still, if it has a drug, so we will do a orthogonal testing kind of thing, maybe on a Sanger sequencing, and check this variant again if there is a drug for it. Okay, so this should not be considered. And then there is CDK12, and then there are a lot of losses. So though this report does not have a copy number loss of heterozygosity score like you have in breasts, but I feel if that is done, so this could have increased loss of heterozygosity score. So this is an unusual case. We don't have anything for this in NCCN guidelines. So what I feel for this case is two things. One, so is this BRIP1 mutation, could it be germline? So I like to check that. So that will give me more confidence, like that, okay, there is copy number loss. And if this patient doesn't have any option, and this is definitely a pseudopapillary tumor of pancreas, which has gone aggressive, then maybe a PARP inhibitor therapy could be suggested. But definitely I will like to have a germline testing, and if possible, LOH score. Then, and I give it to Anush, if she wants to say something, she can add to it.
Thanks, Mashmi. So yes, yes to all that, what Mashmi said. Again, at the family history, I would really like to know if somebody else has had a positive, anything related to GI cancer in the family. And about the fancy is just a one copy loss. So I would, I don't know if this panel has covered the BRCA1. If not, I would like to know if BRCA1 is also functioning. If apart from that, we know we have a whole list of unknowns, clinically unknown variants. And so what I would do in an ideal setting is we'll review all those VOS while the patient is on follow-up. I'll check whether any of them comes back as pathogenic. If so, I'll think of sending the patient for a clinical trial for maybe the targeting beta-catenin or FGFR3 if that is significant. I know the DOS part, but even then. And we do have the DNA damage repair pathway and the immunosuppression system pathway here in this particular case, looking at the entire profile of variants, including VUS. But then, so yes, this is a heterogeneous tumor, likely to be resistant to a single target if you're trying to target one particular clone. Before thinking about PARP inhibitor, I would want to know the status of the opposite allele. So I would really want to know if FANCJ, the BRIP1, is completely lost, the function is completely lost or not, and if the BRCA1 is intact or not. So yeah, these are a couple of lacunae that I see in the case or the NGS report. And that's how I would go with it.
I like to add, it's a very good point which Anu made, that this is a single copy number loss. So one thing which I want to highlight, that when we are doing sequencing NGS, so what we are looking is the DNA, the RNA, and the copy number. So nobody is looking at the methylation status of the other allele. So we don't actually know that thing. So that has to be kept in mind. So, and usually it's most of the tumor suppressor gene, if both the alleles are knocked off, then only the function is gone.
Great.
So I think that's why I said a surrogate like a LOH score would maybe give us some idea that, okay, can you go ahead if you're planning to start PARP or something like that. So that has to be kept in mind.
And how many FANG-J losses would be BRCA positive as well? Is there any correlation between the two?
It
No,
depends on the clinical profile.
Okay.
It depends on the.
both
So-
are DNA repair genes. So
Yes.
So if this is a case, if this patient has positive family history as well, then I would really think about a co-occurring loss.
BRCA.
So like just, for all pancreatic cancer patients, we routinely do now BRCA1 and BRCA2 testing. We do it in early pancreas, locally advanced, and patients with metastatic pancreatic cancer as well. Metastatic SPEN is extremely rare. And I mean, I have seen one patient who was a 27-year-old girl. We actually discussed her in the molecular MDT, and this is a second patient, so I don't think it's the same one. She's 32 years old. So one concern I have, and I think this applies to all the three cases which we are going to discuss today, is all of these reports that come in, a patient will come to me and say, why are you not giving me FDA approved, the way it is written, standard of care. The patient is like, you've done the test, you've got the report, and you're not starting me on the tablet. And this is quite simple. I mean, they put oxaliplatin as well and cisplatin.
This is actually, I didn't want to comment because I don't know where this report is coming
Absolutely.
from. So one, they are not FDA. This is a somatic sample. So pancreas, they have approval for germline.
Germline.
They are
yes.
not approved also. But since, yes, it's a very valid point. Good you raised it and the clinician raised it. So I can now take it forward. Yes, it is not done. It should not have been like this. So it could have been suggested, but not as a FDA therapy, which has been put up in.
We're going to add all these points in our guidelines.
Yeah.
Yes, Anu is driving that because, remember, somatic is what you acquire, what is tested on the tumor. For those of and germline is, usually I sometimes check with patients also whether they've really had a blood test from where they have come when, our patients go to different, for different opinions. So germline testing usually is done either on saliva or blood. And most of the time we do it on blood for our patients, and it's completely different. And as Dr. Maushmi said, olaparib, niraparib, and all of these drugs are approved in advanced cancer for a very specific indication in pancreatic cancer. And that is, patients who've had a response to platinum-based therapy, and they've had it for at least 16 weeks, and then we can give them these PARP inhibitors as maintenance. For FANG-J, yes, this may work, but again, there is no evidence at all. So it's very important when you look at an NGS report, you don't jump and start treatments as recommended in those reports, even though the patient is insisting on it. I had a patient with a TMB of 11, and it was in colon cancer. And as per FDA guidelines, approvals, I mean, the patient wanted immunotherapy. They could afford it, of course. And that's why they were insisting. So again, you have to be very, very clear that you have these guidelines and approvals, but you have to really think for your patient. And, just reach out to your colleagues, I would suggest. So to summarize this patient, I think this patient is being managed adequately. I would not recommend anything based on the NGS findings. Anything else from any of our panelists?
I
any
just
questions?
want to add that most of these reports are some AI generated, where a solid pseudo papillary neoplasm of pancreas is same as pancreatic cancer. So that everything comes, and this is true for so many other tumors which you might have seen. So you, when reading these reports, you have to take it with a pinch of salt, and you have to use your own brain. You can't just follow them blindly.
Now, on that, the labs are supposed to mention their validation protocols, at least in brief, on how they chose the in silico algorithms, what they're following, how they're doing it, whether it's in-house, whether it's an external platform. So all these things are supposed to be there in reports. Only then you get.
Yes.
Yeah, there is very good point in the chat that the levels of evidence. So that is also, in fact, there is a AMP guideline which recommends how the reports should be. All the variants have to be put in various tiers of whichever level of evidence it is based on. So that is ideally it should be done like that. But unfortunately, most of the reports which we get in India are not done in that way.
In
So
that way,
they
I think
should
Dr.
be.
Vidya is making that point, it's
Yes.
a different, it
Yeah,
has to
very
be
good point.
specified.
Yes.
Level 3, level 4. And what about IHC MMR? I think again in pancreatic cancer, I've seen a lot of BRCA positive patients who respond beautifully to cisplatin, gem-cisplatin. But again, I have yet to see an MSI high patient with pancreatic cancer. SPEN, again, mostly the surgeons see them. I've just seen one patient with SPEN in my entire. Any other comments, Shona, Neha? So otherwise, we'll move on to our next patient, Dr. Naga.
Going to the next case, it's a case of 46-year female postmenopausal with stage 4 left side breast cancer with positive family history of uterine cancer with her sister and bile duct cancer with his father. The current ECOG status of the patient was ECOG 1 when she presented to us. The first presentation was in July 2020, where she complained of painful breast lump on the left side. Ultrasound was done on the ipsilateral breast, which was showing the lesion at between 1 to 2 o'clock position, which was 2.3 into 1.4 centimeter. Microcalcification was found with ill-defined margins, and axillary lymph node was 1.2 into 0.7 centimeter in size. Contralateral mammogram showed dense glandular parenchyma, and Berat's grade 4 was there. FDG PET CT showed left breast cancer with axillary lymph node. No evidence of malignancy elsewhere was found. A core biopsy of the lesion showed invasive ductal carcinoma grade 1. Next slide, please. Surgery was performed with left breast conservation surgery. Sentinel lymph node biopsy and left axillary lymph node dissection was done in August 2020. Final margins of the surgery were negative, and out of the pathological regional lymph nodes that were taken out, 26 were positive out of the 29 that were resected. Histopathology showed invasive lobular carcinoma. Perinodal extension was present. Lymphovascular invasion and perineural invasion was absent. HER2 new receptor IHC2 was 2+, so FISH was performed, which showed it was not overexpressed. So we concluded that HER2 new receptor status is negative. ERPR status, that is estrogen and progesterone receptor status, was positive. Ki67 was 25 to 30%. Chemotherapy was started for that patient with cyclophosphamide and epirubicin, followed by paclitaxel. From September to December 2020, she received this treatment. Then radiation therapy was given in January to February 2021. That was a whole breast and tumor both irradiation was given. Following which there was hormonal therapy with tamoxifen from February 21 to Jan 22. In between August 21, mammograph of left breast was taken, which showed upper quadrant post-operative fibrotic changes, and there was no evidence of malignancy anywhere. She presented second time in Jan 2022 with back pain. MRI spine was done, which showed diffuse heterogeneous marrow signal intensity in vertebrae, which was indicating metastasis. There was vertebral compression fracture and spinal cord compression also seen in MRI spine. It was done in January 2022. Then FDG PET CT was done, which showed no local recurrence in left breast or axilla. Integral development of multiple hepatic and skeletal lesions were seen, which was indicative of progressive metastatic disease. So it has gone to the stage of metastasis. A core biopsy of right liver lobe showed metastatic carcinoma with primary from the breast cancer. A surgery was performed with the laparoscopic bilateral salpingo-oophorectomy in February 22, and hormonal therapy was started with palbociclib in February 22, and it is continued. An NGS panel of 324 gene panel was performed in January 22, and the results are displayed here. So I request Dr. Moshmi Suryavanshi and Dr. Anu to take it from here.
So there is a positive family history. That's what I see first. And so please ask the oncologist to send for a pre-test genetic counseling first, and then followed by germline testing, if not done yet. And moving on to, I would just wait, and since they've already started her on Palbo, would just wait and see how she's responding to it. If it fails, then maybe PARPI. But again, even on PARPI, I don't think it's going to respond as much as we would like it to, because of the TP53 loss. I find that quite significant in this case. And also, yes, I do see the higher VAF for CDKN2A-B, but going back to the basics, tumor purity, where the section, where the origin of the section is all, that also counts. So as long as she's doing well on Palbo, you can just keep it under wraps.
Tell me, Dr. Anu, you've got a P10, sorry, a CDH1 loss in a patient with invasive lobular. Would that make you think of a syndrome or no importance to this exon loss at all?
Not in this setting, because look at the family history. Look now,
Yeah.
uterine cancer, bile duct,
Right.
and now breast.
Right.
So it hints more like a. Plus, there is a TP53.
It looks more like a
Like a
BRCA.
BRCA.
But definitely, if it is a lobular and
Then lobular and
CDH1,
CDH1, so I would naturally associate both that
Yes.
on the patient level rather
Correct.
than germline.
Yes.
Correct.
The only thing is TP53 could be subclonal. So yes, TP53 wherever we see, I'll just like to add a little thing to what she said.
Yes.
So TP53 wherever we see it, we are like, okay, poor prognosis, poor. But you should look at the VAF. That is very important. And like this is a foundation report,
Yes.
and now they have started adding VAF.
Foundation wouldn't miss that. That's why I confidently.
So it could be a subclonal. So subclonal could just not be the main thing. So it may not affect that much.
So to be significant, if you can just tell our students what should the VAF or the variant allele frequency be, which should make them think otherwise.
Okay, look, VAF is dependent on the tumor content also. So this is basically a calculated value, which is normal, that is the mutant versus wild, and the wild will depend on how much normal tissue is included in the slide or in the section which was used for NGS sequencing. So it can vary if you vary the section. So you have to keep that in mind.
Right.
Okay? And you should look at the tumor percentage. A report must have, NGS report, that is very important, should have the amount of tumor which was there. It has to be assessed by a pathologist and it has to be reported. So that will give you an idea how seriously you want to take it. If it is 90% tumor and you find a TP53 maybe 3 or 4%, so you can assume that it is subclonal. Okay, so that kind of thing has to be kept in mind. And for other things also, like BRCA2, if you find a lower, usually your germline mutations, okay, so your germline mutations will be somewhere between 20% VAF to 70, 80, even 90% VAF.
Right.
So there you should start suspecting that, okay, these could be germline. Even with 20%, I have seen when you did the germline.
Very good.
So that has to be taken into mind. So
what kind of tumor purity are you looking at when you do an NGS? What is the minimum that you require?
Every lab actually has their own cutoffs. I think 30 is the one that we all prefer right now. But Dr. Vidya is here. They have the new whole exome panel out. They've gone in for an alternative marker like tumor cells per field or something.
Okay.
So what we do is we do a macro dissection. So
Right.
what we try to do is if like the tumor is maybe 10% and the 90% is the wild, you just remove the normal part and you have almost 70-80% of your section as tumor. So the more the merrier. So that
Yes.
is obviously the trick. But yes, at times you have to deal with less tissues and
Exactly.
give them the report. So that is a reality which is there. But try to optimize as much as possible.
So Bhavna, if this patient had a BRCA2 germline, all right, she's young, she's ER/PR positive, she's got invasive lobular, how would you expect her to do on the combination of hormonal therapy with CDK4/6?
I think this is one treatment which we know has an overall survival benefit.
Yes.
And they
yes.
did not actually tease out how many were lobular, how many had BRCA2. So I would actually continue with the treatment, and I would hope that she would actually have a good outcome.
Right.
And my question is with the CDH1 loss and BRCA2. Of course, we'll do germline testing, but
Yes.
should we also be, CDH1 loss, you normally think of lobular cancer and stomach cancer.
Correct.
So
The
these two
diffuse
things
gastric
come in your
syndrome.
mind.
Yeah.
So should the patient have an endoscopy?
Yeah.
Should we counsel the family as well if the germline
If the germline
But
is
if
positive,
the germline is there, so you have
yeah.
to confirm the germline, then only.
Then only we do that.
Then only.
So what percentage will have both CDH1 and BRCA2? I mean, this is very unusual. No? Or is it usual?
No, either.
Somatic. This is
I haven't
somatic.
Somatic is possible. So again, I think making the point which Shona, you made in the beginning as well, we must do germline testing if
Yes.
these pick up. And this can be quite distressing for patients as well when
Of
they see
course.
reports.
Of course. So
and
tell
so
me,
proper counseling has to be done. Yeah.
so if her BRCA2 on germline is negative and she progresses on a CDK4/6, would you go the PIK3 mutation way, or would you challenge her with olaparib?
So I'd probably go with olaparib because I
Yes.
think this hasn't picked up. With all the trials, they had done PIK3 mutation on the archival tissue.
Right.
So, and here we see that PIK3CA mutation is not
negative.
there. So
Okay.
very likely. But we know that the drugs are approved for germline mutation, not for somatic mutation.
Correct. But there is a very small study, if you remember,
Yes.
by Nadine Tung, where
Yes.
which is BRCA extended, where they looked at all these mutations in olaparib, and they
Yes.
found in the patients with somatic BRCA and PALB2, these were the ones to benefit with PARP inhibitors.
Yes.
So I
second
like
line-
to add this. So
Yeah.
right now we only have those LOH scores and your HRD scores for ovarian cancer.
Right.
But if that is available to you and the score is high, so you know that that kind of activity is happening. So you can use it. Like right now, I know, but eventually it will come in the.
It's coming into breast, it's
Yes,
coming
it
into
will come to
pancreas,
breast. Yes,
pancreas
yes.
as well.
Yes, even prostate for that
Yes,
matter.
even prostate.
It
All
will come. So
yes.
that I know till it is not there and you have to take this call. So if you have that value, that will help you take
Of
this
course.
call.
Of
So
course.
this is what I.
Again, biomarkers there. So when we have advanced biomarkers, you're more sure.
Yes.
So now
Yes.
LOH is coming up now.
Yes.
Telomeric allelic imbalance
Yes.
will come up. LST is
Yes.
going to come. So
Yes.
once it comes into the regular practice, you can more confident as to what the biology is.
And Dr. Anu, these tests are available. I'm not suggesting we do it for everybody, but when you've got a tough situation like this and you want to be absolutely sure your drug will work, there's no harm in doing this test for the patient.
These
completely-
foundation people, they give this LOH. I don't know, this may be an old report, but they give LOH.
That's very recent, I think. Foundation
Uh-huh.
just validated their LOH.
So you can use that. Like,
This is an old one, I think, for this patient.
yeah.
Yes.
Yeah, I'd just like to add that the area of post palbociclib, post CDK4/6 inhibitors, what next, is pretty gray in literature right now. A lot of people are looking into it. We saw elacestrant. P10 mutation is what
Correct.
I'm seeing here. There are
Yeah.
trials that are going on, AKT, P10 pathway.
Absolutely.
If
Yes.
there is a trial in the country, next progression, that also could be an option.
Yes.
Yeah.
And then you could even look for an ESR1 mutation, and if you found it, then put the patient on a SERD. I mean,
Yeah.
that would also be an option later on.
Absolutely. Yeah.
Yeah.
So we'll move on to the third case, Shona. Anything else in this?
No,
Yeah.
no.
Yeah.
So to summarize, I think the patient has been managed well. Unfortunately, she started off with a pretty bad disease, highly node positive invasive lobular with primary endocrine resistance, progressed within a year of tamoxifen, and then was switched to ovarian suppression, fulvestrant, and CDK4/6, and hopefully she'll get a decent progression-free survival with the same.
Thank you.
So now going on to the third case, that is the lung cancer case. 61-year-old female with stage 4 lung cancer, first presented with back pain in April 2019. CT chest showed central perihilar lesion with early mediastinal fat infiltration, malignant lung lesion, metastasis to left fifth rib, and also D5, D7, and D8 vertebral body, and few pre-aortic and left hilar lymph node was seen on CT chest. Lung biopsy showed adenocarcinoma. Chemotherapy was started with bevacizumab, carboplatin, and permetrexate, followed by bevacizumab along with denosumab. So it was continued from May 2019 till August 2021. CT chest in June 2021 showed disease progression, which showed increase in size of primary lung lesion with pulmonary nodules with central cavitations. No significant changes were seen in the size of the metastatic lesions. MRI brain showed right high frontal paramedian cortex suspicious area, and chemotherapy was started with atezolizumab, carboplatin, and nanoparticle albumin-bound paclitaxel from June 2021 to August 2021. In June, MRI spine was also done, which showed multiple cervical, dorsal, lumbar, and sacral vertebral body and their posterior element lesions. CSF cytology was highly suspicious of malignancy. So radiation therapy was given to the whole brain and vertebra, and targeted therapy with osimertinib was started from August 2021 onwards. NGS 360 gene panel was performed in August 2021 with the specimen of a lung site that was collected. And this is the report that we got. So now I request the panel to take over the discussion further. Thank you.
Okay, so this is the lung biopsy, which has shown driver mutation, which is L858R, which is one of the commonest mutations in lung adenocarcinoma.
Was this
And-
the same mutation earlier, Moshami?
No, I don't think there was earlier it was done, because that I could not
That was
find.
EGFR positive or negative earlier?
So Dr. Nagar,
Earlier, there is nothing mentioned.
nothing was
actually.
Nothing is mentioned,
Yeah.
ma'am. We
Yeah, so
don't
it
have
was
that
not
data.
done.
Okay. All right.
So
So
in
we
fact,
have this
that is-
directly.
Yeah, in fact, this is like routinely what is done is for all lung cancer patients, this basic testing of EGFR AL cross, at least if you're not still going for NGS panel, is done. And around 35 to 40% of your lung adenocarcinomas are EGFR mutant. So, and there is a generic drug which is very cheap also, which is available, and there are of course many options for that. So, whatever this patients has got a NGS done for lung cancer, maybe probably if a single gene testing was done earlier also, they could have picked up this EGFR mutation, which is a very common mutation, and a targeted therapy could have started. But now when this has been done, so since this is a big panel of maybe 324 gene, we see many other mutations. So that is what happens when you do a bigger panel. So you see many more mutations, which are usually you don't know, or therapy or what kind of influence it will have on your driver mutation. So there is MDM4 amplification, but it is a equivocal amplification. So usually it is known to have shows resistance in patients who are often immunotherapy. Then interestingly, there is MTAP and CDKN2AB loss. So this is quite commonly reported in many malignancies, including lung, and usually these are co-occurrent mutation losses which are on chromosome 9, and they are associated with the earlier progression, but a better response to post-chemotherapy treated patients. So that's what has been reported in literature. This is not in the guidelines, but this has been reported. And then there is APC and there is MLH1, which is probably subclonal. So, but just based on that, yes, EGFR is the main driver mutation. It has to be treated, but a caution is that the patient might progress early. So from my side is to like follow up the patient more frequently, because the progression might happen.
Very interesting, Dr. Moshmi. So I agree with the concept that at least EGFR, ALK, and ROS should have been tested by PCR plus minus FISH and IHC, if not NGS. Given that we got such a common mutation in EGFR, what I like to do if I get a report like this is look at the databases. So ClinVar on PubMed is freely available, because I obviously don't have the extent of knowledge, and if you don't have a molecular tumor board immediately at hand, then just check whether these mutations are co-occurrent and what kind of literature is available. This patient probably could have gotten skipped with EBRD also, possibly. I don't know if he was symptomatic for the brain lesion. Had we known that he was EGFR positive, osimertinib has very good intracranial response rates, and it can decrease the chance. Second thing that is interesting in this case, that the patient got immunotherapy without testing for EGFR and ALK. So most of the data for IO in lung cancer, we do need EGFR and ALK. To my knowledge, there's only one study, that is the combination of atezo, bevacizumab, and carboplatin nab-paclitaxel, ABCP trial, which actually had about, I think, 70, 80 patients of EGFR and ALK post their TKIs. Otherwise, anybody today, any medical oncologist treating lung cancer would definitely check for EGFR and ALK before jumping onto immunotherapy. So that's a bit of an odd point in this case.
So tell me, doc, if you were to treat her first line, suppose this patient had come to you first off and you did an EGFR, ALK, ROS, MET, the basic lung panel, and you found this mutation, what would be your first line of treatment choice?
Ma'am, if everything is permitting and cost is not an issue, osimertinib is the current standard of care.
Right.
It has head-to-head comparison. We have it with the first-line TKIs, not the second-generation TKIs, and there is an overall survival benefit with osimertinib. And if not available, then definitely we have generic versions of geftinib or erlotinib in the market these days. They're quite cheap, around 2,000, 3,000 per month.
Yes.
So patients should have at least gotten that benefit. Yes.
But permit my knowledge, I'm not very good with lung, but aren't these, this is a exon 21, right? That
yes,
we are looking at. And do they not, is there no data to show they don't respond as well as a 19 del to single agent TKI, and that you need something more for these patients?
There is data actually that exon 19 tends to do better, and we tend to have a higher chance of lesser PFS with exon 21. But that is mostly with the first generation TKIs. This data came in when we had geftinib.
When there was no osimertinib. Okay.
Exactly.
All right.
So,
got it.
Yeah.
Got it. So you would still start osimertinib as your first line.
Exactly.
That's great. Okay.
I want to add 2 points. One is there was a CSF done, and I will just by this example like to touch on liquid biopsy. So CSF is a very good resource for liquid biopsy, which is usually not known to many people. So if you are planning, so because I have done a study which has been published in lung cancer on CSF samples. So they are very enriched with these mutations, and not only your T790M, which is a resistant mutation. But if you are suspecting a leptomeningeal disease and you are getting some atypical cells or not atypical cells, or your radiology is plus minus, and if you get a CSF positive, so that could help you decide that okay, this is a clear-cut case. So you can use that on liquid biopsy. And another thing is that there are certain mutations which can co-occur, which are already known to occur with these driver mutation, like your TP53 and
Right.
FGFR-L85R. They are known to have a bad progression, but for this case, like cases like this, there are studies. In fact, there is enough evidence, though it's not been mentioned, that these patients are likely to be poor. They might respond, but they may progress earlier. So since we have NGS, we should as well as use that information to be more vigilant.
So on that, following up on that point, what I see from this particular profile is that she was somebody who was responding to the SOC, but then slowly progressing. So there is a particular resistance because the MTAP deficiency is there, which has already been explained, that it is kind of a treatment response. And now if she progresses on osimertinib, just one point I need to add is please reassess the molecular profile and then only take the next step rather than continuing with the protocol, that regimen that you have at hand. So just because it's an evolving gene.
In fact, in one of our studies, we found around 15 to 20% of these progressing patients on osimertinib to have MET amplification. So there was another, and plus there are other rare targets also which you could get if you are lucky enough.
So
definitely met her too.
Yeah, and FGFR. In fact, I have had one patient who has got ALK translocation.
Yes.
After osimertinib.
There are case reports. Yes.
Yeah,
so go for a broader panel for that matter.
So patients do acquire different mutations, especially in lung cancer during the course due to treatment pressures, and they could be targetable. I think that's the message to give.
Yes, ma'am. So to summarize, we had a metastatic adenocarcinoma lung patient in a female who should have, as per the panel's consensus, gotten a multiplex molecular testing, preferably by NGS, but at least for EGFR, ALK, and ROS, and that it's important to look at the co-occurring mutations also to predict the kind of progression-free survival we will be looking at, and at the time of resistance, either by liquid biopsy or by rebiopsy of the tumor to look for resistance patterns and possible new targets.
Thank you,
To you, Dr. Naga.
Yeah. So now we have come to the end of the cases presented, and now I request the panelists to give a take-home message to the participants.
So, what do you think, everyone? Please post your questions. Otherwise, I think we will. So, for me, the key thing is think twice before ordering a test. Choose the right lab. Counsel your patients well, because when they spend a lot of money in doing the test, you must counsel beforehand that there is a big chance that we're doing this test, but we may find nothing, no actionable mutation. So that counseling has to be done for the patient, and so I think that would be my message, Dr. Shona.
And don't take any hasty decisions without running the patient's history and findings through a molecular tumor board.
There is one question which I think has come up, role of NGS testing in young unmarried 29-year-old girl with FIGO grade 1 endometrial adenocarcinoma.
I'm just answering it as we speak.
Oh, sorry, ma'am. Yeah.
So no, I think it's very important to do an MSI and go further, probably do an NGS for germline to rule out Lynch in this patient. So I think it's very, very important to do a hereditary panel, of course.
Yeah, I think even a pole mutation should be done. In fact, if you don't need to do NGS, but okay, if you have the money, then go for NGS. Because these patients, you could be able to save fertility, because pole mutant patients, they usually do very well. So that is and there is other TP53, and should also be done, because that it puts you in that high copy number high category. So there is a cascade based on the PROTECT trial, which is available for your endometrial carcinoma testing, which includes all these genes. So
Yeah,
that has to be done.
A 29-year-old with the endometrium is not going to do so well. So you need to be a little careful with that.
Poll, if it is poll, then yes,
then
they will do well.
Yeah.
Yes.
Dr. Maushmi, any last thoughts? And then we'll wrap up.
Last thoughts is, so whenever you are going for NGS sequencing, the quality of reporting has to be good. You have to look at the accreditation, the quality parameters. So a good report starts with good material. So the pre-analytical material has to be good, and you need to send it, and you need to the clinician needs to talk to the lab person and be in touch with them. So I think, and if you have any doubts, you should go back, bang them, talk to them, fight with them, but then come to a consensus.
Dr. Anu?
I see a question on the chat for me. I'll just read out the question. What is your perspective on the integration of NGS with other omic data, such as transcriptomics and proteomics?
So just briefly, please.
Yeah, okay. So I think the question is on how do we integrate, and what is the future of that? Yes, this is exactly what I do, but now on a research scale, and I'm trying to bring the integration into the clinic, because at the end of the day, it's not epigenomics, not genomics or transcriptomics, it's a protein and the functionality of the protein that matters. So that is where we are heading to on a multi-omic level.
Thank you. Dr. Neha?
Yes, ma'am. I think it was a very educational session today, a good start. And I'm a recent DM graduate. It's not been a year, but yet I'm outdated already. So I still have to read. So this just reiterates the need for molecular tumor boards, the kind online or whichever that you were already mentioning, and probably on a national level. It's very, very important to stay updated. Every day the data changes.
Yes, and I think Dr. Naga will let you know when we start the molecular MDTs. Navya has been part of those before as well. Thank you, Dr. Naga, for everything, and thank you, Navya. So just we can close it now, Dr. Naga.
Yeah, thank you, ma'am. I thank each of the panelists for sparing your valuable time and being a part of this entire session. This is the first of its kind that we have started from Navya. And I believe we will be continuing to do similar webinars in coming days, and your support will be what we will be expecting and requesting you to. And
this was an all-woman panel. I forgot to mention that, which is amazing. And it happened by chance, actually.
Amazing.
Yeah.
And I thank all the participants for attending to this webinar. I believe you have got answer to all your queries, and you have got a take-home message and a learning that you have got today. And if you still have any questions, you can always send it to my email ID, which you would have received when you registered for the session. Otherwise, you can please note it down. I will just post it here. My email ID is nagashayana@navya.care. So you can send it to me, and you will get a email further to this after the webinar, where also my email ID will be there. So you can ask your question. We'll try to get back to you with the answers as much as possible. And we will keep you informed about the forthcoming webinars. And please make yourself free and join us for the future webinars as well. And I thank all of you once again for joining us today, and have a great weekend. Thank you.
Thank you. Bye-bye. Bye. Bye. Bye.